It's so great to see so many people here in person finally. Goodness, life will resume and become normal someday, hopefully soon. And welcome to all the members who are online. I think we have quite a few people who were not able to travel today. So by way of process, people who are online, please feel free to put in your comments, questions, anything you want to say. In the chat. I'm going to be monitoring that here, and we'll make sure we keep you guys engaged. And we will also give you the opportunity to speak if you so desire. My co-chair, Don Hirschman, is right here. Don?
Yeah, so welcome everybody. It's been great, seeing everybody in person. We wanted to take this opportunity with us all here to have this be more of an open forum. We're going to be going for the next 3 days with back-to-back lectures, but this is our opportunity to really hear from you, whether you're online, and we will definitely include everybody that's online as well, or whether you're here in person, so that we can use our resources in SWOG with the Hope Foundation to help figure out how to solve problems. That's really why we're here. And so what we really want is to make this like an open dialogue as much as possible, so that we can hear about a variety of issues that you may have at your sites, ideas you have, suggestions you have, so that we can put them into practice. And what we ask, I guess, here is that if you are speaking, speak into one of the microphones, because if otherwise the people online can't hear you. So if you are speaking, if you can come up to one of the microphones, that would really help with this whole hybrid situation. So with that being said, we know that this past year, and with the news and everything else we've heard about, that there are a couple issues that have affected us all. And one of the things that has been affected all of us is staffing. There's been issues with lots of resignations, with staff turnover, and that's really been challenging. And at the same time, we've expanded our use of telehealth services. There's a lot of talk about, what we can do in the clinical trial world remotely versus what we need to do in person. And so I think we thought we would just start the discussion on issues related to staffing and remote work with clinical trials.
Yeah, how are things going? We've just lived through 2 years of hell. But we know that it hasn't been as hot or as frozen over for every single one of us as it has been for others. So we would love to hear your ongoing experience. I think we've been kind of feeling the pulse of this for the last 2 meetings now, the last 2 years of meetings. But as we're getting closer, maybe we hope, to the end of the pandemic and all the transitions that we will have to go through to learn life post-pandemic, what's going on? We've heard of the Great Resignation. That personally came home in my NCORP late last year. We were essentially skating along immune, and then wham, come November, bing, bang, boom, we just had person after person after person turning resignations, including new hires. So what's that been like for people? Yeah.
We can always count on you, Jeff.
I feel like a broken record, because we've been talking about this, and I think our manager is giving a presentation at the OISHI today about our situation. So part of our problem, I think, was we have our DNA was different of our NCORP, the way we evolved, because we don't do any treatment at the UH Cancer Center. It's all community-based treatment. But we had done all.
Wait, can you explain what that means?
In other
I'm not
words,
sure I
our
understand.
cancer center does not have its own hospital and it
Okay.
doesn't have its own clinic. So we depend upon private clinics and hospital-based providers for all of our trials. So we're really, I think, almost unique. In other words, we have a NCI designated cancer center. However, it's all community facing. We've done a few trials back in the days, prevention trials, bringing volunteers to the center, but treatment trials and all the trials we're doing now are all in the community, essentially.
I think that's wonderful.
That's what we want.
That's what we want.
No,
So we need to learn more from you.
No, the problem is that our staff has been doing all of it, even at the hospital sites, which it worked for a long time. And we had career, people working there. We always had some difficulties, but then more recently, we've had younger staff, most of whom I think were not really interested. We have one of our senior staff here. She's here. She can make a comment about, she's probably one of two senior staff and the most functional staff that we have, senior CRP. Her name is Erin, by the way, and I give her a shout out. And but most of the other people have been relatively junior, not really interested in career. Many of them wanting to do this so they can get a resume going into medical school or NP or something else. And then after COVID, things got worse. We've been trying to restructure because we had the resignation for a number of reasons. Some of it's one of our CRP3s, who's working for us for about 2 or 3 years. She had some experience. She left to work exclusively from home for another cancer center for more money, 100% at home. Other people have left to go on for school. And the problem is that, let's just say Hospital X, I don't want to name any of our hospitals. One hospital helped with screening and consent, but did nothing else. No trial conduct, no data management. So we were left with, so when we had the shortage, about maybe close to 70% of our staff, 65% of our staff, we're really, really struggling even to keep up patients that are already on study. It's just been a disaster. And they're wanting to know, well, why aren't you activating new trials? Why, and like, well, can you help us out? Well, maybe if you give us some money, we can help you out, maybe, but we're not necessarily funded, for that, because you expect when you put in your grant, you say, oh, these sites are helping you. Well, they are helping us, except for the military site that really did a lot in the past, which is where I worked. They really were not doing that much. So it's left, so our shortage of people, and the reasons left for all those other, things, some of it, no education, no mentoring, maybe we weren't doing a good enough job, but many of these people weren't really interested in a career.
Yeah.
So we have been hit, I think, harder than, let's say, a typical MU-NCORP that has the hospitals, hopefully there others may have multiple sites and they can sort of fill in, or at a cancer center. I talked to somebody from CHOP and he told me that they lost 6 out of their 7 COG CRPs, within 1 year. But then people from some of the other programs helped and cover, at least, even though they weren't COG, there was some coverage. We don't have any coverage.
So that's one of the things that we would love to hear. Solutions.
You want to hear a solution?
Yeah.
Well, we have establishing a career ladder. We're establishing a mentorship program. We're hiring a dedicated educator. We are working, unfortunately, we have to work with the state supported foundation, and we've been problem with salary. We're trying to increase the salaries to a certain extent. So we do have a plan and we're working on it. I'm like one of a working group that's working on it, but our problem is, I think, worse than most other places.
Yeah, we would love to learn from you for sure. I think a few comments coming on the chat, but do we, so clearly staff turnover has been a bear, and I think it's everyone in this boat, I suspect.
Yeah, it's, I mean, not to belabor the negative, but somebody leaves, everybody there is working twice as hard, they get burnt out, and then they leave right when you hire somebody that hasn't been trained. And, that's the cycle.
Just cascades. Yeah.
So we'd love to hear how sites have dealt with this. So we could think of like some both local solutions and central solutions, because, this has been really hard on everybody, but there may be within this, creative ways where we can think about centralized resources that can help when sites have challenges like this. So what have you all been doing to deal with staff shortages? Has it just been decreasing enrollment? So come up to the microphone. We'd love to hear from you.
Please identify yourself and your institution.
I'm Kamara Mertz Rivera. I'm with Upstate Carolina MU-NCORP, and I'm also the director of Gibbs Cancer Center in Spartanburg, South Carolina. And I can speak for our affiliate site, Spartanburg, South Carolina, that we lost about 8 staff members in a period of 6 months, and again, for a variety of reasons. And our solution at the time, just to cope, to make sure that those that were still there were engaged and not overwhelmed, we paused on enrollment, which was not what we wanted to do. It was very hard to make that decision. We had leadership support to do that, specifically on treatment trials, because those are the higher acuity for our staff. And our cancer control and cancer care delivery research moved forward. We had other affiliate sites that were able to continue enrollment. But what we did is we also have a career ladder, and we pivoted a bit from RNs, hiring mostly RNs, and we have a job description that includes and expands entry level bachelor degrees in some form of science. And what that did bring is a lot of really great applicants, but at the same time, we realized we had to start from the scratch, from foundation, with onboarding. And we're working on diligently on our orientation for research. So we do find that the workbench and other, SWOG has the CRP or CRA support, and we make sure that everyone that is new or even needs a refresher attends those. But right now we're doing a soft opening, and we're really happy to say we're starting to enroll and refer, screen patients. So we realized that we had to pause.
Did you develop standard operating procedures to codify these modifications you made?
Yes, so we are also working diligently on our standard operating procedures and rolling those out. And that's really part of our foundation and helping onboard staff, because every site might have a different process, but the foundation is where it needs to be, is quality data, and that we're doing things that are safe for our patients. And the onboarding and the foundation is imperative that we get it right from the start.
Yeah, absolutely.
And we've also allowed, we've identified staff within our department to elevate them to a new, a role to really enhance their career and hopefully show our appreciation for, staying there.
So I think a lot of like feedback and appreciation for the people that are there is key. Is there anything in the training that SWOG offers that could help? Is there anything we could do differently to help with some of that onboarding or constant training or, anything along those lines?
Melissa Faust from Upstate Carolina MU-NCORP. Hello.
How are you?
Good. We're moonshot friends.
Okay.
The only thing I'll say, and I haven't gotten on in the last few months, but the SWOG platform that the CRA training maybe needs to be looked at. I don't mean to be negative, because
but that's what we want to hear.
I print out the SWOG manual for all the new staff so that they can go through it. But the SWOG platform keeps taking you back, and I don't know if anyone else has ever done the course, but
It's kind of a pain.
yeah, it's very difficult to navigate.
Thank you. Well noted.
I'm taking notes, so.
Hi, Ken Matthews. I work at Swedish up the hill here. And one of the things our organization did, I'm crossing my fingers and I should knock on something because we've got the highest staffing we've had in the past several years. And one of the things that's been successful is we had just a number of people just jump off at the beginning of the pandemic for places that offered work from home. And, our regulatory team was down to just a couple people at the beginning of the pandemic. And now I think it's 8 or 9 or something. And one of the things that my department, the oncology research department, did was we just allowed people to work from home pretty much 95% of the time. I mean, there's regulatory people that started, and I remember when they started, we were shipping computers to their homes and things like that. And I remember thinking at the time, is this a good idea? Because these are new employees, that we don't know from anybody, and we're hiring people and shipping computers out, and they've all stayed. And one of the things that has been successful was we brought people in at lower levels. I think someone from upstate might have mentioned that too, is hiring at a slightly lower level and then trying to find applicants that are interested in kind of working their way up a career ladder. So we've had a bit of success with our research coordinators in that way. Because we have some research coordinators that are more inclined to maybe just work on data or work from home. And then we have others who are more interested in facing patients. So we found a way to kind of divide up some of that work too, where we have some coordinators that work 80% or so from home, and they do mostly data entry. And then the other folks are in the office most days of the week, unless they don't have patients, then they have carte blanche to work from home. But the working from home thing and that flexibility really increased our retention, and hiring at a slightly lower level also helped us so far avoid, I think the thing that you mentioned, I'm sorry, I forgot your name, where you would have people, they'd start and then they'd be like, oh, I'm going to med school. And, you just lose that right away. So we found we were hiring at the mid-levels. That was like a regular occurrence, like once a year or so, we'd have people jump off to, do a med program somewhere, as opposed to when we're hiring at the lower levels. We haven't run into that yet.
So who has adopted remote consenting and other things and how much has that helped? So a few hands go up, meaning a few people are doing remote consenting.
Tell us about some of the benefits and struggles with doing trials remotely. I'm on an ASCO task force myself, looking at how to bring clinical trials, to patients in their environments. And, I think there's a big yin and yang, right? Like you want to be able to do it, but you're worried about the data quality. So any positive and negative experiences with it so that we can learn?
So I work exclusively with cancer control and CCDR studies, and we have adopted many remote consents, but I'll tell you that we're hemmed in by our organization who we have to have wet ink signatures. So it's going to sound bad, but for example, for the NCI COVID study, which was very time sensitive, they had to be enrolled within a certain amount of time after their positive test. I was FedExing consents to patients with a return FedEx envelope. We would do the remote consent over the phone, make sure that they actually wanted to do it, actually consent, and then we would have FedEx go back and pick up the consent and bring it back. Because
so is the wet, sorry to interrupt, but is the wet ink consent an NCI policy or is it an institutional?
It's our institution.
So they won't go by DocuSign or anything
not.
Like that?
And so my workaround for that, because again, with us pausing treatment enrollments, my team really felt we wanted to continue to enroll. We just had to think outside the box. And it sounds like a funny thing, but COVID has affected everyone, and the mail service was not dependable. In addition, our mail has to go from our building to another city and then mail out of their mail room. So we would not get those consents back in the 14 days that we needed them. So that's what we were doing. We were also, we were doing all kind of crazy things, but remote consenting was wonderful and is wonderful, particularly for some of our trials. Or we'll go and meet with the patient, give them the consent, and let them take it home and think it over. And then the fact that they don't have to return to our facility to be consented, because we have people that travel, distances to go to our facility. So thank you. And I hope that remote consenting continues.
Is there anything that the NCI, other organizations, SWOG, or any place else could do to help with that institutional policy? If that, given the fact that, I signed a mortgage remotely, like you can do all kinds of things remotely now, like, what you could do to sort of change that policy. Is that set in stone, or is there anything we could do to advocate for you?
You could make a policy, because, we all use the CIRB now, and have them, I don't know, say it's okay, write a policy that we could take to our research compliance department, our regulatory department, so that we could do a DocuSign or something of that matter. But like I said, we had to pivot. We had to think outside the box, and it worked for us. I mean, we put a ton of people on, on trials during this time period, but
Right.
FedEx is not the most inexpensive way to do it.
Yeah, so I think the so-called relaxation, what they call them, relaxation rules in relation to public health emergency. We every year we have asked whether which ones will stick post-crisis and which ones might evolve away. I don't know that Donna, are you aware of any feedback yet
From the consenting, at least?
Yes.
I didn't know if we have some of our colleagues from the NCI. I don't know if there's any plans on switching that back.
This is Bernard. Can you hear me?
Yes, oh, hi, Bernard.
Thank you.
How are you all? I'm glad to hear your voices. Sorry to miss seeing you. Yes, from what I understand, the consent, the remote consent, I think that's something that will very likely stay. This is the impression that I get from speaking with WATA, is that this might be something that it appears to be very efficient, and so this is one of the relaxation rules that may stay. I'll need to, if you have others, please let me know if you have questions about other rules like this.
Are there other, so we talked about remote consenting. I think that seems to have been very popular. Are there other adaptations in the relaxation rules or any other workarounds that people have come up with that we might want to communicate back to NCI, yay or nay, which ones were super helpful, which ones were not quite so?
Yeah, I can only imagine that some of them are still, relaxation rules are up in the air, such as treatment. Some of the, I guess, well, again, how the different sites are choosing right now to provide, to perform these protocols, to perform their trials. Just, from that angle, that's something that I guess there are so many different elements with that. And so each of these things would have to be looked at. The remote consent seems to be sort of like low-hanging fruit, easy to deal with, but the others are more challenging depending on the type of trial that you're dealing with. By the way, I failed to, I was wondering who the first questioner was, the first person that asked questions. I couldn't pick up his name and where he was from.
I think that's Jeff Barenberg.
Oh, that was Hawaii. Jeff. Okay, all right. I couldn't hear his voice very well. Okay, thank you.
So there have been several comments in the chat. I think we need to make sure we acknowledge them. Christina Gardner talked about the turnover of coordinators is intense at nearly all of our NCORP affiliate sites, definitely creating struggles. New staff are very inexperienced, unskilled, and untrained. Many new coordinators leave before they become competent. Several sites struggling with the loss of medical oncologists as well. Vacant positions difficult to fill. Is that a universal experience? I think nobody is shaking their head, disputing that. So that's a common experience. Gary Doolittle, in Kansas, we had a turnover of 110 staff within the clinical trials office. No question, our accrual has suffered. Maybe somebody has it worse than you do. You think?
Right.
Yeah, I know. Isn't that true? Going back to, and then Amy Kofanos, going back to Kamara's comments on education, one thing Alliance recently started is a virtual open forum for clinical research professionals that occurs every month. Sometimes it's educational presentation, other times discussions like this. The goal is to provide interactive education throughout the year. Given the newness of so many staff, it would be great to see other research bases offer this as well. So this is an idea.
Just to pause on that, like I'm seeing a couple of nods in the audience. Like what that be, that's something we could easily implement. So it's great to hear these kinds of solutions. What would be a good focus for that? What would be, what's missing?
So she says SWOG has a lot of great reading materials, but interactive materials are always helpful. So she's asking for more interactive materials.
Excuse me. Hi, Jeff St-Elore with Pacific Cancer Research Consortium. And two things. One thing, really appreciate SWOG's training for their new coordinators. And I would say one thing with the opportunity for participants to engage through the remote access. I know with our NCORP, a lot of new coordinators, new research nurses have participated in those trainings. So in years past, you had to be in person to attend and just not always able to do that. So having that as a remote option has been amazing. And so really appreciate that. You know, I feel like especially some of our smaller sites, and I know that there's can be scholarships and such, but being able to have that remote option has been huge. And so if there's a way for them to continue that, maybe expand it, would be great. And then a follow-up with that would be if there could be a regulatory track for new staff. So I think like with coordinators, it's great. I will say I've attended some of the meetings and I'm always like, I wish some of our reg people were here because there's certain elements either with CIRB or other things. We talk about, bringing on new staff, and if your reg person has left and so they're kind of cobbling it together, I feel like out of all of our team members, sometimes they have a bit more challenges to get up to speed. And I appreciate the reg people in our group. We've got, it's branched out a bit. So we've got some good mentorship that goes on. But if at the research-based level, if we could have kind of a regulatory track for kind of like new people, kind of what they need and how to flow with that, that would be, I'm sure, appreciated probably from a lot of our sites.
Okay, that's good.
That's an excellent point. I mean, I can tell you at our NCORP, one of the things that it used to be that everybody did everything, and separating out these complex functions has definitely helped with deviations and things along those lines, delays in terms of IRBs, and the world is very complex. So having a specific regulatory track that people can stay up to date in terms of current practices, what's allowed, what's not allowed, especially in terms of the CIRB, which is also changing a lot, I think is a great suggestion. So it sounds like maybe something that is fixed from a training perspective that could be like modules to help train your staff, but also something interactive so that when questions come up or people can learn from each other on a regular basis, that would also help. Is that, I'm seeing some nods for the people on Zoom. Okay, so that's something we can definitely look into, because that's a great suggestion.
So lots of chat things coming in the chat. Please go ahead.
I was just going to add, I attend the Alliance CRP sessions, and I think they're wonderful. And one thing that I think, I used to be a coordinator, it'd be great if the research bases all sort of followed the same rules. I mean, an example is loss to follow up. You know, SWOG has their loss to follow up, and then other research base, you're reaching out and finding out how they want you to handle it. I mean, that's just one example, but it'd be great if there were some cross research based sessions, because for me, the best part of those alliance is, yes, I'm getting information, but it was just the chance to commiserate with other people and
Right.
hear that other sites had also lost coordinators, because how were we to know? Because, you know, we haven't been together. So it's just so nice to have the support of, you know, my friend that I've never met in person.
Right.
And it'd be great, you know, maybe SWOG could get together with Alliance. and
Yeah,
we could do
oh,
one.
definitely. We can definitely do that. That's a great suggestion. In terms of, I know everybody's just starting to think about our having to put in our progress reports for the RPPA, you know, for the sites. And I didn't see a section in that, because it's probably, you know, been fixed for a long time, in terms of, you know, how COVID has affected your site and staffing, and how that's affected accrual and data quality and other issues. And so it would be great to hear how those kinds of issues are going to be viewed from the NCI, and how that information should be conveyed.
Yes, this is Bernard again. Sorry to interrupt. I just wanted, I appreciate that, Don, for you bringing that up. And also just a quick opportunity to thank all of you for your work during these very challenging times, during these past 2 years of COVID. And again, you know, for you all attending, at least those of you, all of us attending, but those of you that are actually in Seattle right now. I want to just mention that when we receive the RPPRs, we do take into account the impact that the COVID, that this pandemic has on operations within each of the NCORPs. So we do report that when we review the information, and they are taken, you know, of course, it's taken, you know, it's you know, it's very taken very seriously. So just wanted to let you all know that.
Yeah, thanks, Bernard. Kate Castro from NCI. I'll just add, so on the guidance that you received in part 2 of the guidelines, which were sent out the last week of March, I don't have the date on the top of my head. March, you might. It was like 29th or 30th. Okay, 29th or 30th went out to everyone. In the guidelines, you will see, you're correct on, there's not a specific area for COVID, but you see B2, which is where you tell us about what you've done in the past year. And we have offered many bullets there of things that we would love to hear about. It's not a requirement that you touch every one, but you will see in there that we do have what are some of the issues with staffing. We did include a bullet specifically on that this year, and also on COVID. There is also a section of barriers and challenges. That's the standard section of your RPPR. So please feel free to put things in either place. That's fine. And as Bernard says, we do pull all that forward when we're doing our reviews. So either section B2 or barriers and challenges are both good sections.
Great, thank you. I think we have a bunch of questions.
The chat is active. People are really participating. Thank you. Lots of love for the regulatory track idea, you know, so brilliant. People love it, seems to resonate. So let me just track back up a little bit. So Susan Notmeyer says that we really need guidance and acceptance of video visits. So telehealth, using telehealth to improve access to clinical trials work. How does that sit with people need for guidance? maybe some feedback from NCI. I know there's probably some active work behind the scenes to see what's possible. Anything we might, any nudges from anybody?
So in terms of like other protocols we've done at our institution, like our own institution video visits, we've really looked through our protocols to think about what really requires an in-person visit, and can any of those be changed, right? Like, do we really need a physical exam on some of these visits? What are the things that we can get in terms of toxicity assessments, that fulfill the requirements of making sure we're getting all of our AEs and even sending patients PROs remotely, and what do we actually have to give in person? And so I don't know what other people's experiences with that have been and what patients' acceptance has been about coming in for appointments.
Yeah, along those lines, Phil Lammers at my institution has a comment about, well, SWOG and NCI can't really do much about salaries, of course, but SWOG and NCI could lessen the workload significantly by looking in detail at protocols to lessen data reporting requirements, exactly what Dawn just said. For instance, do patients really need data collected at multiple cycles of a particular regimen? People on long-term follow-up, can they be seen, done annually instead of every 6 months, and so on and so forth? So yeah, there's the challenge of recruiting enough staff, but there's also the workload aspect. Can we blow this up a little bit and remove the parts that are not really?
Yes, Marge Good with the NCI. Dr. Dorschel actually did a nice presentation at the ASCO meeting. I think you attended, Dawn, and I think he's at the high level of NCI and being very aware of these issues, and that is one focus that he's particularly honing in on, is looking at what data do we really need for these patients and for how long do we need it?
Right.
To drag it out for years and years, that's probably, when are we using it? And how are we using it? So there's a really intent look internally to be looking at that. But it's also, I think, an opportunity to encourage the research bases to look at that too when they're developing their protocols and trials, to see how, do we really need to like copy paste what we've been doing in the past and carry it forward? How much data do we truly need to capture the science, the answer that we need? So
right. It's really important that we think about that long-term, that we think about modifications as we move forward to these protocols, especially I think in terms of exactly what you're saying, in terms of the long-term follow-up, knowing something, but not making patients come in for that. Especially those long-term follow-ups. I don't know how much of that is done remote now, but my feeling is that patients are coming in for those visits. And maybe that's a good opportunity to start to figure out how to minimize data collection. But most importantly, those are the follow-ups that really probably don't need in-person, visits at all. And we could maybe save both patient time, staff time to really take a deep dive into that. The other thing that came up, and this is a bigger issue, is in terms of patients and sites' comfort level in terms of directly contacting patients. So there are some HIPAA rules where you have to disengage patient contact information from a protocol per se centrally. But one of the things, I've been thinking about is both in terms of follow-up, but also in terms of creating cohorts of patients that could be directly contacted for future studies, is how to unburden the sites for that. Like, is there a different mechanism we could set up that centrally collected information directly from long-term patients? How does that sit with people?
My age is coming out just a bit, but didn't we do that with PCPT?
So there's a component of PCPT and the WHI and other trials where that's been done on a trial by trial basis, and patients consent and reconsent to be directly contacted. And they were able to put up some firewalls. That was before like everybody had lots of different social media and electronic ways of getting the patients directly. Now we can try to figure out better mechanisms for direct contact. So I don't think PCPT had all that in place. But what do sites think about, consenting patients to be contacted by investigators at SWOG or SWOGCancerResearch directly?
So have SWOG contact patients enrolled into SWOG trials, take that burden off the hands.
Right,
of
for
the-
long-term follow-up. Just an idea I had that both for maybe some simple long-term follow-up, but also for being then eligible for survivorship studies or other things.
Sounds like a great idea to me. I mean, if SWOG is willing to take on that burden and invest, and the financial investment that it'll require. Are there any potential objections to that idea? Yes, please. Please introduce yourself.
So my name is Jenny. I'm from Theta Care. I'm part of MU-NCORP, so I'm from Wisconsin. Just a comment, I think a lot of times, we look at as far as like the grant, we look at, our treatment trials, our CCDR trials. A lot of times we forget about all of our long-term follow-ups and all the time commitment that does take. And so that's really can be a big burden on the staff. So we have so many focuses, but we have so many long-term, for instance, like at our site, we have TMIST open and we have 950 some patients on that trial. And those are all follow-ups that are going on. So as far as like our grant, we get nothing back for all of those follow-ups that we're doing. And so 950 just for that one trial, not including all the other ones that could be like trials that are until death that we're following them
So
for.
you would be in favor, it sounds like.
100%.
Yes, it sounds like, okay, great. Ann Geiger has a comment that has led to a few responses. A reminder, FDA has a strong regulatory role in consent. Very senior NCI leadership have been lobbying hard and suggest that we make that we be sure to let NCI Clinical Trials and Translational Research Advisory Committee be aware of this issue that we have raised today, as they are at the center of efforts to address trial challenges. And she gave a link, including the roster, and reminds us that Dr. Blanky and Doolittle are members. So
sometimes with those committees, like we try to bring this information that we hear directly from you up because it's invaluable. You're boots on the ground, dealing with things that we don't always, or the leadership doesn't always experience on a day-to-day basis. And that's why these things are really important, because the ideas generate from the people that are actually, in the weeds.
Kelsey Bridges says, commenting on remote consenting, we also have rural populations and older adults that may not have access to equipment to complete via DocuSign. Also, from a logistics standpoint, DocuSign has to be set up to be 21 CFR Part 11 compliant. It does not automatically meet these requirements. So is there a rurality, elderly patient barrier somewhere in all of that? And then along those lines, Christina Gardner says, remote consenting has been very helpful. We appreciate that opportunity. We use DocuSign more now, which works great. There are a few trials that allow a verbal consent without needing signatures, which is a unique, effective option. We appreciate SWOG considering options such as these verbal consent scripts in appropriate trials, such as CCDR, cancer control trials, and to request a HIPAA waiver if appropriate. So these are, now we're going to capture these texts, right? We will have, the chat will be provided, will be accessible to us at the end of the meeting. Lots of great ideas in here. The comments are really coming thick and fast.
Is there a way, I'm just asking our IT colleagues of saving the chat?
Yeah,
Okay.
this
All
is
right,
a
good.
super rich conversation. We won't be able to finish all of it, but there is a lot of, activity in the chat room,
Right.
and brilliant ideas we need to make sure we capture.
So I have to say, I don't know what the rules are for verbal consent, and where it's required or allowed or not allowed in trials, but that's certainly something we could bring back to our regulatory group and even the CIRB in terms of thinking about that.
Yeah, so Christina says they have sites that are using telehealth to see all patients, with a shortage of medical oncologists.
Can she unmute and tell us about our experience?
Christina, can you get on the microphone and talk? You're giving us all this rich feedback here.
Yeah, can you hear me?
Yes.
Yeah, so we've noticed that at some of our, particularly the rural clinics, they have lost their medical oncologist, and they have associated clinics, like maybe it's a series of 3 or 4 clinics in rural Kansas, and they will have maybe a radiation oncologist on site the day that a patient comes in and gets therapy, or maybe there's one medical oncologist left, but they can't see all the patients that they have. So they're using telehealth for patients that actually come into the clinic. So the patients are there on site. We can get their vitals, we can get a weight, and we can get blood pressure and temperature and things like that, but they're not having a in-person visit. And so on some of our trials that that were created well before we were doing so much telehealth, they don't have an option for the H&P to be telehealth. There may be an assessment that's required that isn't approved in the protocol, or sometimes we've reached out to the study teams and just said, hey, can this be a telehealth visit? And the answer is no, we're sorry, the trial wasn't designed that way. And so that's been a very big challenge for some of these very rural areas to figure out how they keep patients on trial and keep compliant when the patients are having telehealth visits exclusively. So anything we can do to be more flexible with that telehealth would be very helpful in those situations.
So let me ask you this, because one of the ideas I've heard has been partnering with primary providers locally. And, I guess that would require some kind of, I don't know if it requires some kind of accreditation or, that they're listed in some way, but that sort of doing a hybrid where a patient can go to their doctor, even if they're not an oncologist, down the road to get some of the primary, like as you were saying, like vitals or bloods or whatever else is needed in person, and then have the equipment so that they could do a telehealth visit right then and there with the study team. So as a hybrid kind of model. Has anybody else done anything like that?
Well, the challenge that I'll just jump back in and say, one challenge that we have to be very careful about is if the study is at an active treatment point where you've got people assigned on a DTL or an authority log, then those primary care individuals, of course, aren't going to have completed the city training that we require. They're not going to be registered investigators with the RC, with the registration credential repository. So we can't put them on the DTL. So we can't assign them those tasks.
But maybe that's something we can think about.
Yes.
Like maybe that's something we can think about in terms of having sites, especially sites that care for patients in rural locations, or maybe patients that would be willing to go to a local doctor, but they don't have internet access themselves, and something could be set up locally, in terms of increasing the diversity to clinical trials, because we want to think about what those barriers are so that we can have more rural patients go on. We can have more patients that don't have internet access. And, patients that have long, that can't miss work or have long commutes, somehow bridging this as an opportunity.
Well, I guess one question is, will the PCPs have the bandwidth or the willingness, desire to do that? Because what you hear from them all the time is they're overburdened. But I think it's an idea that is definitely worthy of exploring. May not be for everyone, but there may be bits and pieces of it that others are going to be willing to do. We got 7 minutes to the end. We had actually intended to end at 7:45, but boy, this has been very interactive. I'm going to take one last comment from Kelsey Bridges online. It would be really helpful if each trial would have something similar to an investigators meeting that goes over the protocol, nuances of the protocol, special training if need be, and offer an opportunity for questions and feedback. If recorded and offered on CTSU, this would be extremely helpful when onboarding a new staff member. Sounds like a great idea to me.
Yeah, I mean, I think a lot of it's great, actually. A lot of the trials now are having like these in-person, site initiation visit kinds of things when a study activates. But I agree with you. I don't think anything's been done virtually, and there's no reason why we couldn't do something on Zoom for every new study and then keep it on the SWOG website to do exactly that, a site initiation visit that is in perpetuity, so that when, I think that's what you're saying, so that when, staff come and go, they can watch that when they get assigned to a new protocol.
Yeah, and then one last one. Betsy Barnick says she's on the Alliance CRP committee, and they would be happy to work with SWOG on joint training sessions. So
great.
We have a nibble. Excellent. Wow, I can't even go through everything. The people have been really in there.
Yeah.
Great. Well, maybe we can just wrap up. Any last words, from NCI or anybody else before we close up? This has been really stimulating.
Yeah. So we're here to help, and we can't do everything everybody says, or at least all at once. But there are definitely things here that we can do. And that's why keeping these lines of communication open are so critical, because, we're also at sites, these NCORP sites, we struggle with it the same way you do. And so, taking what has been a terrible experience and trying to pluck out the good and figure out how to take advantage of some of it is really our goal.
Yeah, so this is Leslie Ford from the NCI. I just wanted to reiterate what Ann Geiger said, and we all have our hands tied to some extent by FDA regulations. And the FDA regulations for our trials, it operates under a different regulation than for pharma trials. So we need to do everything we can, but some of the issues about remote consent and things like that, that's what Jim has been working on, and highlighting it for CTAC is, obviously anything we can do, but some of these things are not us being rigid.
Mm-hmm.
It's the FDA.
Higher authority.
And in the regulatory environment in the hospitals, they might see different regulations if it's a pharma trial, or different rules if it's a pharma trial versus an NCI trial. Just something to be aware of.
Yep. Yeah, we have to use all of our advocacy,
Yeah.
In terms of what we can control and what we can't. Great. Anything else?
No, just
I guess I'll just finish by saying, having said that, we have been blown away by how the NCORPs have been able to adapt. And if you look at the accrual curves, they have rebounded and in some places gone beyond what the pre-pandemic accrual was, both on the prevention and control side, CCDR, as well as on treatment. So it's really been gratifying.
Yeah, and I'll tell you.
I'm very proud of my staff. That's, you know, that's.
Yeah.
And I'll tell you, that is because of several things. It is a labor of love. There is clearly a need that the NCORP's, the idea of NCORP serves, and that need is gargantuan, you know, and I think we're only still just scratching the surface of what's possible. The nice lemonade out of the lemon of the pandemic is actually we are being forced now to innovate in ways that will allow us to serve our communities much better. So thank you all for this engagement today. This has been really very enlightening. Thank you.
Yes. Thank
And
you
to
all
all
and
the
have a
people
great
invited.
meeting.